వారానికి 2 సార్లు ప్రోగ్రామ్ వస్తుంది. నేను చూస్తలేను. ఇది పెట్టుకొని మనకు తెలియదు. ఇప్పుడు నాట్ లైవ్ ఆన్ యూట్యూబ్.
దాంట్లో వస్తుంది.
అట్లా వెనక కూడా బ్లర్లో అవుతుంది. అంటే ముగ్గురు పేరు మీద ఓరేషన్స్ ఉన్నాయన్నట్టు. నంబర్ 1 ఏ లక్ష్మీనారాయణ, ఐ శ్రీధర్రావు అండ్ వి భూమిరెడ్డి. ఏమైనా రవీంద్రరావు గిట్ట కనబడుతుండ్రు.
Hello, hello.
సార్ కూడా వస్తున్నారు.
Good evening, everybody. Because of some rain problem, we could not make the event sharply by 8 o'clock. It will be started another within 5 minutes. Sorry for the inconvenience. రామ్కన్ వచ్చాడు కదా
వచ్చినారు.
రవీంద్ర సార్ అక్కడ రెడీగా ఉన్నారా? అన్నా గుడ్ ఈవినింగ్ అన్నా. అన్నా గుడ్ ఈవినింగ్. నరేంద్ర అన్న గుడ్ ఈవినింగ్ అన్న. మా
గుడ్ ఈవినింగ్.
సెక్రటరీ ట్రెజరర్ వస్తున్నారు, వాళ్ళు సమ్ మెటీరియల్ తీసుకోవడానికి వెళ్ళారు. ఒక 5 minutes లో మనం స్టార్ట్ చేస్తున్నాం. మన రవీంద్ర సార్ ఒకసారి, రవీంద్ర గారు స్పీకర్ రాలేదు ఇంకా లైన్లోకి.
Hello, I am here. I am audible.
ఎస్ సార్. సార్ గుడ్ ఈవినింగ్ సార్.
Good evening, Vasan. Good evening.
సారీ సార్, మన సెక్రటరీ అండ్ ట్రెజరర్ బోత్ ఆర్ ఆన్ ద వే సార్.
No problem.
Another 5 minutes, maximum 5 minutes they will be joining, sir.
No, it's okay. No issue.
Thank you, sir.
Come, please come.
Thank you.
బ్లాక్ బోర్డు పెట్టుకున్నాడు.
అయ్యా స్టార్ట్ అయ్యి 10 minutes అవుతుంది. అది ఉంది, అది శ్రీనివాస్ పెట్టుకున్నాడు లోపల. వస్తున్నాడు. ప్రోగ్రామ్ నేను హాఫ్ అన్ అవర్ వెయిట్ చేశాను. 4 days చేస్తారు, 2-3 50 సార్లు. మనకు అనిపిస్తుంది సరిగా మనం పంపించిన లింక్ అది పర్చేస్ సరిపోతుందో రీసెట్ చేసుకోవాలి. అంటే ఫ్యామిలీ ఉంది
ఆ లైట్ పోయింది, ఈ లైట్ లేదు, ఈ లైట్ లేదు, ఓన్లీ దీంట్లో ఉండడం వల్ల బాగా రిఫ్లెక్ట్ అయ్యింది 20. సో మీరు మాట్లాడిన తర్వాత ఈ లైట్ అనేది దీంట్లోనే తెలిసి మళ్ళీ సేమ్ ఫస్ట్ లాగా దాంట్లో యాక్చువల్గా అయితే 3 ఉంటే అసలు మొన్నట్లాగా ఏ ప్రాబ్లం లేకుండా ఉండదు.
అరే రామ్, రవీంద్ర సార్ అసలు పంక్చువల్. స్టార్ట్ చేద్దాం.
Hello. 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 హలో హలో వసంత్
సార్ గుడ్ ఈవినింగ్ సార్.
నేను ఎంటర్ అవుతున్నా. డిక్లేర్ సమ్ పీపుల్ ఆర్ ప్రాబ్లీ సైన్ ఇన్. సమ్ పీపుల్ ఆర్ సైన్డ్ ఇన్. డిక్లేర్ ద ప్రోగ్రామ్ ఈస్ స్టార్టింగ్ విత్ ఇన్ 2 minutes అని చెప్పండి అంతే.
I declared and I already told.
ఓకే రైట్.
Anna, second floor. Third floor.
యా. సో మనకి శ్రీనివాస్ వచ్చాడా?
వస్తున్నాడు అన్న, అంత వే ఉన్నాడు
శ్రీనివాస్. ఓకే, వీళ్ళు ఎవరెవరు సైన్ ఇన్ అయ్యారు? మన నరేంద్ర సార్ ఉన్నారు,
రవీంద్ర సార్,
జీఎన్మూర్తి, కర్మకొండ. ఓకే, వీ కెన్ స్టేట్ దిస్. వాళ్ళ సివిల్ రెడీ ఉన్నాయా? 4 members. జీఎన్మూర్తి సివి, కర్మకొండ లక్ష్మణ్ సివి, నరేంద్ర సార్ సివి
ఉంది సార్. ఉంది
నరేంద్ర సార్ సివి
ఉంది సార్.
దెన్
విజయ్ కుమార్ సార్.
ఆల్ 3 doctors. విజయ్ కుమార్. ఓకే రైట్.
సార్ గుడ్ ఈవినింగ్ డాక్టర్ నరేంద్ర సార్. గుడ్ ఈవినింగ్. మీరు అన్మ్యూట్ చేసుకోవాలి, మ్యూట్ ఉంది మీది. గుడ్ ఈవినింగ్ సార్.
గుడ్ ఈవినింగ్ సార్. అయిందా? స్టార్ట్ అయిందా? ఓకే సార్. am I audible?
Yeah, you are wonderfully audible.
Thank you.
So if I stop video, okay, video on unte kuda
వీడియోను స్టాప్ చేయి.
Srinivas Rale. Okay. Good evening, all of you. I welcome to the second oration of Karimnagar IMA. We have 3 annual orations. This is second oration. First of all, I request Dr. Vasant Rao to come on to the dais, President of IMA Karimnagar. I request Dr. P. Kishan sir, Awards Committee member, to come on to the dais. IMA Karimnagar. Every year, as I told in the earlier, every year we are conducting 3 orations, annually 3 orations. One oration, last week we have completed Dr. A. Lakshminarayana Karimnagar, IMA Karimnagar oration, and that was, the orator was Dr. Prem Kumar. Now today we are conducting Dr. I. Sridhar Rao IMA Karimnagar oration, and the orator is Dr. C.H. Ravinder Rao sir, MS General Surgeon. And now I request Dr. Vasant Rao to preside over the
Topic రాసావా? What committee chairman? Good evening, everybody. Sorry for the late. Respected my senior colleague, Dr. P. Kishan, member Awards Committee, Secretary Dr. Ramkaran. I request Dr. Srinivas to join, Treasurer Dr. Srinivas Alagandula, and today's chairperson, Dr. Y. Narendra, retired superintendent, Civil Hospital, Karimnagar, and today's speaker, Dr. C.H. Ravindra Garu, retired civil surgeon from Surgery Department, Civil Hospital, now presently working in Prathama Institute of Medical Sciences, Nagnur, Karimnagar, and other members of the IMA Karimnagar, and President of Awards Committee, Dr. Pollard Srinivas Rao Garu, and other senior persons, Dr. Boom Reddy Garu, Dr. Bhagya Reddy Garu, Dr. Kishan, Dr. Vijayendra Reddy, State President of IMA, Telangana, Dr. I. Sridhar Rao Garu, today's oration on Sridhar Rao sir name, as you all know, he is a very senior defense personality, blessed with 2 sons, Dr. Praveen Rao and Dr. Ramakant Rao. Praveen Rao is working with Yashoda Hospitals, Secunderabad, as a orthopedic surgeon as well as knee replacement surgeon, knee and hip replacement surgeon. Ramakant Rao, who is also orthopedic surgeon and spine surgeon, working in hospital. Sai Krishna Neuro Center, Kachigoda, Hyderabad, and other senior members and other members of IMA Karimnagar. Welcome you all for today's second webinar of IMA Karimnagar. Very unfortunate to have this webinar, this meeting online due to death of, as you all know, COVID, all over country, near about 600 doctors in our families have expired. Now I request all our members on the dash to please stand up and mourn for 1 minute. Please. Thank you. I request Dr. Kishan to awards committee member, please speak few words.
వాళ్ళు అడుగుతున్న క్వశ్చన్ ఇది.
Respected President of IMA Karimnagar, Dr. Vasant Rao, Secretary, Dr. Ram Kiran, Treasurer, Dr. Srinivas. I'm here today on behalf of Dr. Pollard Srinivas Rao, Chairman, Awards Committee, is also immediate past President. So Pollard Srinivas Rao already declared the results of Awards Committee in the last oration. To review the briefly. Actually, Awards Committee and under leadership of Dr. Pollard Srinivas Rao and Dr. Vasant Rao presidentship has done a lot of exercise, because everybody knows because of COVID situation, to get the speakers to have a physical conference is very difficult. So irrespective of that, we completed all procedures. We declared 3 orations. We selected 3 orators, and we declared the benevolent funds, 4 benevolent funds, out of which 1 is a medico fund, and we declared the professional excellence awards. This year it goes to Dr. Madhusudan Rao and Dr. Patel Gopal Reddy. Both are senior IMA members. And only the one more pending work with the Awards Committee. We have to celebrate a Doctor's Day celebrations generally. And generally we used to give felicitation to senior most doctors in Karimnagar, 3 to 4 doctors or 3 to 5 doctors every year. This year also we selected 5 members, but we are not conducted the program because of the COVID. Today, the 3 awardees are willing to accept the felicitation, and I'm very grateful to all 3 members. One is Dr. Karmakonda Lakshman, retired superintendent of Civil Hospital. Second is Dr. Vijay Kumar, is a senior anesthetist in Karimnagar. And third is Dr. G.L. Murthy, is also senior ophthalmologist of Karimnagar and senior member of IMA. All 3 members are accepted to have a felicitation today, and they are all 3 awarded as IMA Karimnagar Dr. B.C. Rai Awards. And I am now, we'll start with President permits, we'll start the felicitations. Ram Kiran, you please take over to declare one by one, then we can go ahead with the, before oration, we'll complete very briefly within 10 minutes, 5 to 10 minutes, we'll complete the felicitation of, which is pending in IMA Karimnagar branch. Thank you.
Now I request Dr. K.K. Lakshman sir. Sir, Lakshman sir, have you joined?
Can I audible? Hello?
Dr. K.K. Lakshman, sir.
Yes, sir. Yes. I'm here.
Okay, now, okay. Good, I want to see you.
Dr. K.K. Lakshman, sir, is one of the B.C. Roy awardee.
Now, before going to CV of Karmakona Lakshman, felicitation of presentation of Dr. K. Lakshman with IMA Karimnagar Dr. B.C. Rai Award. Madam, I'm requesting, Madam, we are celebrating this because everybody accepted to receive the presentation at their houses. Now I'm requesting Madam Lakshman to give the gold medal. Madam, please put the gold medal.
Patal garu meeku malli avakasham vachedi.
Then garlanding.
Patal madam. Where is Dr. Shiva?
Next is Shal. Madam. Certificate, Madam. Certificate of award. Certificate of appreciation. And memento. Sir, this is as award committee has decided in recognition of your services as a senior member. Sir is also a retired superintendent of civil hospital and a senior psychiatrist, and he is already president-elect of Karimnagar Psychiatric Society. He is taking over after Bhagya Reddy. Thank you, sir, for accepting the this award. And I think I am requesting Dr. Ramkiran to read the CV of Dr. Karmakona Lakshman.
Thank you, sir. Dr. K.K. Lakshman, sir, born in 1957 in Karimnagar district, and his schooling was in primary schooling was in Bombay. His primary school was in Mumbai, and his high school and intermediate was in Karimnagar, and he completed his MBBS from Usmania Medical College and post graduation in psychiatry from Usmania Medical College, and he joined in government service, and he occupied various positions like as assistant civil surgeon, and he was superintendent of government hospital Karimnagar, and he retired. After his retirement, he established his private practice in Karimnagar and serving the people of Karimnagar. Thank you, sir. Thank you for accepting the award.
Great applause to a few words.
Sir, ఏమైనా చెప్పండి సార్, ఎనీథింగ్, few words from awardee.
Thank you very much, sir, for felicitating me by our Karimnagar IMA Association. I am very happy and also thankful to award committee selection members, Dr. Kishan Rao and Dr. Poladi Srinivas Rao Garu and others. And I am very happy for this felicitation. And I wish our IMA Karimnagar branch is one of the second biggest branch in our state. So already we reached once national level post also by our father of IMA, Dr. Bhumireddy Garu. So like that, one of our IMA branch leaders like B.N. Rao also will near future may get highest post in national level also. I wish for that. Thank you very much, sir, for your kind felicitation to all executive body, IMA Karimnagar. Thank you very much.
Thank you. Thank you, sir.
Lakshmananna, congratulations. And also congratulations for the post of president elect, our psychiatry association Karimnagar. మా మేడం చూడలేకపోతే ఒకసారి మా ఐఎంఏ డాక్టర్స్ అంతా మేడం చూస్తారు, కొంచెం మీ పక్కన కూర్చోబెట్టుకోండి. మేడం గారు నమస్తే అండి. థ్యాంక్ యూ మేడం. మా శివన్ కూడా తీసుకురావాల్సిందన్న. ఓకే, థ్యాంక్ యూ అన్న. థ్యాంక్ యూ మేడం, నమస్తే. నెక్స్ట్
Next awardee, Dr. G. Lakshmanamurthy, sir.
లక్ష్మణ్ కన్నడ డాక్టర్ స్పెషలిస్ట్ ఎవడతారు కదా అక్కడ ట్రైన్ కదా.
The presentation of award, IMA Karimnagar BC Rai Award, starts with presenting the medal, presenting the gold medal. Madam, I am requesting Madam Murthy please, to present the gold medal. Thank you, Madam. Then please garland the doctor. Sir, you can unmute, sir. Yeah. Garland, madam. Garlanding. Full and end, madam. The certificate. Memento, madam. Certificate of appreciation. Have you received the garland, madam?
Yes.
Full and end, madam.
Received it is outside.
Full and end. Probably somewhere misplaced. Thank you very much. Now over to Ramkiran to read the CV. This is the awards committee, and IMA EC unanimously decided to award Dr. G.L. Murthy, the senior ophthalmologist, for his contribution. And now I'm requesting Dr. Ramkiran to read the CV of Dr. G.L. Murthy.
Thank you, sir. Good evening, sir. Dr. G. Lakshmanamurthy, sir, born on 10/5/1957 at Dharmapuri in Karimnagar district, and he completed his MBBS and MS MS ophthalmology both from Kakatiya Medical College, and started professional career in Iran in 1984, and then he married to Madam Manorama in 1986 at Karimnagar, and he joined government services in the 1991. And he continued the government service, and he retired in 2015 as civil surgeon ophthalmologist at district headquarter hospital Karimnagar. And sir has two sons, Dr. Nikhil, elder one Dr. Nikhil, and he is pursuing DM neurology, and then younger son is Nihar, and he is a software engineer. Thank you, sir. Thank you for accepting BC Rai Doctors Award. Sir, say a few words, sir.
Hello, sir. Hello. Am I audible? Huh?
Yes. Lakshmananna, congratulations first of all. Please, Anna.
Hello, sir. Respected President and Dais, Dr. Vasant, respected Secretary, Dr. Ram Kiran Ulas, and Dr. Srinivas, Treasurer, and the awarding committee chairman, Dr. Pollard Srinivas, and Dr. Kishan, and others on the dais. First of all, I thank you very much for organizing this felicitation. So what I felt initially is you must have taken award committee chairman and the members and the IMA body must have taken a lot of pains to organize this event. It's definitely to say, for me, this is very difficult to organize it. You must be a good organizer and good service. So after that, I think all of us know our IMA Karimnagar is ahead of all the districts in our state. Most of the times, in service or go on strike at all India level, at state level, we are first in first. I mean to say for the last 24 years, I have been seeing so many courses you have conducted, so many orations, so many organizations, regional conferences, zonal conferences. We go on telling there are so many events you people have conducted. So it's not that easy. This is all because of our IMA core committee effect. Once again, I say definitely our IMA body and others, they are quite hardworking. Not only this program, awarding committee, Oration, other conferences also, we are very, very, very forward when compared to other deities. So thank you one and all. Thank you very much. Once again, thanks for organizing this felicitation. Okay, Varnish.
Thank you, Anna. Thank you very much for your good experiences of life. Thank you very much.
Next, Dr. B.C. Rai Award is for to Dr. Vijay Kumar, anesthesiologist.
విజయ్ వసుంధర కొద్ది కలర్ వేస్తే కొద్ది నల్లగా ఉండు కదా జుట్టు స్మార్ట్గా ఉండేటోడు కదా.
Presentation of IMA Karimnagar Dr. B.C. Rai Award to Dr. Vijay Kumar. Starts with, I'm requesting Madam to present the gold medal. Thank you, Madam, for accepting to do felicitation. And next, garlanding Dr. Vijay Kumar by Mrs. Vijay Kumar. Shawl. Presentation of shawl. Certificate of appreciation. Memento. Thank you, Madam, for this wonderful job. Some of the awardees are rejected garland, probably because of the COVID situation. But we provided everything on behalf of IMA. Thank you very much. And over to Ramkiran to read the CV of Dr. Vijay Kumar. He is a senior anesthetist in Karimnagar. Over to Ramkiran.
Dr. Vijay Kumar, sir, he did his MBBS from Usman Medical College and he completed in 1983. And he did his post-graduation in 1990 from Gandhi Medical College and a senior residency in cardiothoracic anesthesia, 6 months senior residency. And now he is practicing freelance anesthesiologist in Karimnagar. And he has got, he is in service, government service from 2018 onwards. Thank you, sir. Thank you for accepting Dr. B.C. Rai Award, IMA Karimnagar Award. Thank you.
Now, say a few words on Mathu and personal life.
I cannot express how grateful I am to have all of you here with us tonight. To be considered for a BC Rai Award is a great honor and respect for me. Thanks, IMA. I especially thanks Dr. M. Vasantrao, the President of IMA Karimnagar, and Ram Kiran, General Secretary, and A. Srinivas. Especially thanks to Dr. Boom Reddy and Kishan. Thanks, IMA. And special thanks to Jube and organizers.
ఓకే ఓకే నైస్ నైస్ మా మేడం కూడా చూడండి మన డాక్టర్స్ అందరినీ మేడం పక్కన కూర్చోండి. మేడం నమస్తే అండి. థ్యాంక్ యూ అండి. థ్యాంక్ యూ వెరీ మచ్ విజయన్న.
Thank you, thank you.
Now we'll go to very overview of
Acute pancreatitis.
overview అంతే కదా. It is already late. Now I request Dr. C.H. Ravindra sir to start the topic. An overview on first. Okay.
Now, presentation of Dr. I. Sridhar Rao, IMA Karimnagar Oration Award to Dr. C.H. Ravindra Rao, sir, today's orator.
I'm requesting Madam to present the Dr. I. Sridhar Rao, IMA Karimnagar Oration Award Medal to Dr. Sridhar Rao, Dr. Ravindra Rao, sir. Thank you, Madam. And requesting Madam to garland Dr. Rao. Net shawl, Madam. Presentation of shawl. And presentation of certificate of appreciation. Presentation of memento, Madam, from IMA Karimnagar. Yeah, in the memory of Dr. Vasant Rao and his team. Presentation of citation, Madam. Thank you, Madam. This award is awarded by the awards committee. Sir, please keep all the things, sir. Please keep all the things with you, and put the citation also. Madam, give citation in the lap of sir. And this award is awarded by awards committee by screening the different candidates. Sir is a senior person. Now I'm reading the citation. Dr. Chennadi Ravindra Rao was born in the year 1948 in the village of Korem in Karimnagar district. He completed his schooling and intermediate in Karimnagar. He completed his MBBS from Kaktiya Medical College, Warangal in the year 1972. He got his post-graduation degree in general surgery from Usmania Medical College, Hyderabad. He was the assistant professor of general surgery in Usmania Medical College for 6 years. He worked as a consultant surgeon in Iran for 2 years. He also worked as tutor in urology department at Usmania Medical College for 4 years. He rendered his services as a civil surgeon and surgeon at the district headquarters hospital in Karimnagar for almost 10 years. He took voluntary retirement in the year 2001 and joined Pratima Institute of Medical Sciences as a professor and head of the Department of General Surgery till 2018. He was medical superintendent at Pratima Institute of Medical Sciences. Currently, he is working as a surgeon and director of medical education, that is DME, at Pratima Institute of Medical Sciences. He is a life member of many eminent bodies like Association of Surgeons of India, Association of Minimal Access Surgeons of India, and Indian Medical Association. He was unanimously elected as chairman of ASI Telangana State Surgeons Association in the year 1917 to 18. He has attended and moderated various scientific sessions in conferences at the national and state level since many years. He conducted the annual state conference of Telangana Surgeons Association held at Karimnagar in the year 2017. I think everybody remembers the memories of that conference. He is the recipient of various prestigious awards, is awarded the best accomplished surgeon in all aspects at the first annual Telangana State Conference held at Warangal. The Lifetime Achievement Award in recognition of his valuable services for the humanity and the legendary work in the field of surgery, education and teaching and social awareness by the members of Writers Corner Warangal in 2017, and many more awards he got. His main areas of interest are learning and practicing the techniques in the field of surgery. He has a keen interest in the passion and having passion for teaching undergraduates, medical students and postgrad students in Pratima Institute of Medical. We used to witness his commitment as a teacher. He has many publications under his name in various scientific journals. Indian Medical Association is proud to have a member like you, sir. The awards committee and executive committee of IMA Karimnagar has unanimously decided to honor you with Dr. I. Sridhar Rao, IMA.
Hello. Hello.
Hello.
Power పోయింది ఇక్కడ power. వాళ్ళు మైత్రిలో ఉన్నారంటే అక్కడికి రమ్మ
పవర్ పోయినట్టుంది సార్.
పవర్ ఓకే 5 minutes కూర్చున్నా వస్తుంది 90%. పెద్ద వర్షం కూడా ఏం లేదు. కిట్ వస్తుంది తీసేస్తాను మళ్ళీ ఏం వేసుకుంటాను. గోల్డ్ మెడల్ ఉంచమన్నాడు. అంటే మైత్రి హోటల్ అంటే మన పక్కకే. నేను అనుకున్నా IML అవుతుంది అనుకున్నా, కాదన్నమాట. అంటే I have to go there and deliver the lecture. That luxury of delivering the లేదు వాళ్ళందరూ మాట్లాడు. నేను ఐఎమ్ ద ఓన్లీ స్పీకర్ టుడే. ద ఓన్లీ స్పీకర్. అది కాదు, వాళ్ళందరూ ఏంటంటే వాళ్ళకి ఏదో అవార్డ్స్.
మీరు కనిపిస్తున్నారు లైఫ్ హ్యాన్సెట్ ఉంది, మీరు రైట్ సైడ్ చేసుకోవచ్చు సార్. మీరు కూర్చోండి సార్, మీరు కనిపిస్తున్నారు. ప్రోగ్రామ్ మంచిగా ఉంది సార్, మీరు కనిపిస్తున్నారు, మీరు రైట్ సైడ్ చేసుకోండి సార్. ప్రోగ్రామ్ ఉంది, పవర్ ఉంది, లైవ్
Hello? I am audible? Hello? Hello?
Sir, you are audible, but echo is coming. Echo.
1 minute. Hello? 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 I think we can use this audio and ఒక్క నిమిషం. దేనికి? హలో, అంటే వాయిస్
Yes, sir, you are live.
Hello, Narendra sir.
Hello, I'm okay. I'm audible.
Okay, sir. Audible, sir.
Audible,
Audible, sir.
Okay.
Dr. Narendra sir.
Yes.
I request
Hello.
President IMA Karimnagar to come on to the dais as chairperson.
Yes.
I request Dr. Narendra sir, Senior General Surgeon, to come on to the dais as a chairperson.
Yes, sir.
Hello?
From there only.
Hello.
Dr. Hello, sir.
Hello?
Sir, Narendra sir.
Hello.
Audible, sir?
Yes.
Okay, sir.
Audible.
సార్ నరేంద్ర సార్ అన్మ్యూట్ చేసుకోండి సార్. Dr. Vasantrao, present IMA Karimnagar. He completed his MBBS degree from Kakatiya Medical College, Warangal. Kakatiya Medical College, Warangal. And he did his diploma in anesthesia from Kakatiya Medical College, Warangal. And then he did his MD anesthesiology in Usmania Medical College. Then he got fellowship in cardiology and fellowship in diabetology. Now presently he is working in government service. He is a deputy DMNHO and a program officer TB at Rajanna Sirsilla district. Thank you for accepting, Dr. Vasantrao. Now Dr. Narendra sir is a senior surgeon in Karimnagar. He was born in 1948 and he passed his MBBS in 1972 in BJ Medical College, Pune, and he passed in December 1976 from the same medical college and Sassoon General Hospital. And then he joined government service and he joined government service in January 1980 to April 2006 in various capacities, and he retired as civil surgeon and medical superintendent DCHS from Government District Headquarters Hospital, Karimnagar in 2006. Now he is, then after retirement, he joined Pratima Medical College as a professor of general surgery, and now he is doing private practice in Karimnagar. Thank you, sir. Thank you for accepting. Now, I request chairperson to invite orator.
ఇప్పుడు స్క్రీన్ షేర్ చేయాలి కదా మనం, అప్పుడు చేయాల్సి ఉంది. ఇప్పుడు
డాక్టర్ నరేంద్ర chairperson, sir.
Hello, sir.
Hello.
Sir, Narendra sir.
Yes, yes. Good evening, everybody. Yes, already accepted. I am in the chair. So I request Dr. C.H. Ravindra Rao Garu to
Hello.
Excuse me. Sir, Ravindra sir, please start, sir. Narendra sir, there is a problem unnattu, sir.
Shall I start?
I already requested him to start the lecture. Yes, sir, please go ahead.
Vasantrao,
Yes,
shall I start?
Sir, please, sir, please.
Okay.
Please start, sir. Thank you, sir.
Good evening to one and all, to all IMA members. Dr. Vasantrao Garu, President IMA and Presiding Officer. Dr. Ram Kiran, Secretary IMA. Treasurer Dr. Srinivas and is my colleague. Dr. Kish and award members Dr. Kishan, Dr. Vijay Mohan Reddy and Dr. Pollard Srinivas Rao. And my sincere listening to Dr. Boom Reddy Garu, who is my guide and senior. And I also I am very thankful to Dr. Narendra Garu for to accept to preside this meeting. Now, and at the outset, let me thank IMA members for giving me the opportunity and to speak Dr. Sridhar Rao's IMA oration. I'm really glad and I'm humbly accepting it. I will try to do the justice for that. The confidence you have reposed on me, I will try to do justice on that. A few words about Dr. Sridhar Rao Garu. His relation with me is unique in the sense we hail from the almost same taluka. We are neighbors for the last 20 years in Karimnagar. And almost he is a role model for me in a practice. Why I have made him a role model is for his scientific and ethical practice. And he is the longest orthopedic surgeon who is doing a lot of service to the Karimnagar public. And you will be surprised to know that he has not stopped his orthopedic services even during COVID time also. It is a greatness of him. And I request all of the young orthopedic graduates who are watching this program, they can emulate him and they can make him as a role model. With these few words, I would like to proceed with my topic today. My topic today, I have already, my screen is seen. Are you able to see my screen?
Yes, sir. Yes, sir.
So I am going to talk about overview of acute pancreatitis. Probably you might be wondering, why did I choose this topic? This is one of the commonest acute abdomen that we are likely to encounter in our day-to-day practice. And who are the clinicians that are likely to be encountered? Physicians, surgeons, pediatricians, even gynecologists and critical care doctors. And moreover, I am giving you from the Pratima point of view, at least every month, every week, at least 2-3 patients of pancreatitis will be getting admitted in its various forms. And taking into consideration all these things, I have chosen a topic which is of interest for most of the general practitioners, physicians, and surgeons. Now, before I proceed with the topic proper, it's my customary to introduce what is the anatomy of the pancreas. Why I wanted to show you the anatomy. It is one of the most difficult organ clinically evaluate, even the investigations wise. Of course, now we have got some investigations to evaluate, but earlier days there was no investigations available. So that made a pancreas is one of the most difficult organ for a clinical practice. Now, having said that, it lies, let me remind you a few things about the pancreas. It lies transversely across the posterior abdominal wall at the level of L1 and L2. And what is it is a J-shaped, retort shaped. It is 15 to 20 centimeters long, 2.8 to 3.7 width, and its thickness, and it weighs 90 grams. And it's a good, I would like to remind all my colleagues about the basic anatomy of the pancreas. See, it is, as it is depicted, it has got a head, neck, uncinate process, body, and tail. Head can be divided into 2 components, head proper and uncinate process. This is a very important part of the. Now, I am just giving you briefly about the head. Most of the problems of the pancreas are located in the head, which is sandwiched between the C-loop of the duodenum. It has got 3 borders and 2 surfaces. And another interest component I would like to highlight to you, these are the ductal systems. This is the duct of Wirsung, that is the duct of Sartoni. And why I am stressing on this point is one of the cause of acute pancreatitis is congenital anomalies like pancreatic division. This is now we are doing a lot of work on the pancreatic arterial supply, which is going to help most of the times when we are doing surgeries. Now, before I introduce my acute pancreatitis, let me give you what is acute pancreatitis and what is a chronic pancreatitis. That's very important. What is meant by an acute pancreatitis means acute inflammatory changes which are reversible. That's an important point. And moreover, another point is it has got an acute relapsing pancreatitis. So now, but today we are going to deal with an acute pancreatitis. And what do you mean by a chronic pancreatitis? Wherein there is irreversible changes. That means every time patient gets into attack of a chronic pancreatitis, some damage is going there and it is irreversible. But today our area of interest is acute pancreatitis. We mean by an acute pancreatitis where there is an attack, but there is no changes in the pancreas. Now, I would like to divide my lecture into these 2 components. What is definition, incidence, etiology, pathophysiology, clinical features, assessment of severity, investigations, management, and complications. This is the usual practice for any presenter. Now, before I go, I wanted to introduce what is called Atlanta classification, which is 2012. What is the importance for a general practitioners and general physicians and all those things? 2 of the 3 criteria must be satisfied if you want to make a diagnosis of acute pancreatitis. What are the characters? One is a characteristic abdominal pain, that is upper abdominal pain, elevation of the pancreatic enzymes, and characteristic findings in the CECT. Any of the 2 criteria must be there before we pronounce that the patient has got an acute pancreatitis. Now, acute pancreatitis has got 2 components. Most of you know that. It's very important to know which type of pancreatitis we are dealing when you are managing that. What are the 2 components? What are the 2 types I would like to say? Acute interstitial edematous pancreatitis. It is common. Fortunately, it carries wonderful prognosis. 80% of our pancreatitis that we see in day-to-day routine practice is acute pancreatitis, which is edematous pancreatitis. Another component which is very problematic component is the acute necrotizing pancreatitis. The involvement is 10%. It may lead to necrotizing pancreatitis. The necrosis may lead to an abscess or a walled-off necrosis, pseudocyst, and so many complications are associated with necrotizing. And it's a challenge for the clinicians to manage that. Oh, Malla. Next slide. Yeah. Yeah. Now, again, definition: an acute condition presenting with an abdominal pain of threefold size with serum levels, characteristic findings on inflammation and CECT. I have already highlighted to you what is an interstitial edematous pancreatitis and necrotizing pancreatitis. Now, before I am going in detail, I would like to stress on one point. See, acute pancreatitis has got an early phase and late phase. Early phase lasts up to 1 to 2 weeks, whereas the late phase starts after 2 weeks and which may persist for months together, sometimes 3 months, 4 months. And it lasts for 1 week. Most of the times it is associated with, early phase is associated with the systemic complications. When the patient is presenting with a severe pancreatitis, he is likely to have systemic complications, which are reflected most of the times in the early phase. In the late phase is dominated by the local complications. That every clinician must remember the difference between the systemic complications and the late complications. That's why you are focused when you are managing an acute pancreatitis on the systemic complications during the early phase of the pancreatitis. Now, what is the incidence? This is the most important. We are not able to have any data from the Indian perspective, but from the since long 10 years I am working in Pratima Institute, most of us, we see at least weekly 1 or 2 cases. Actually, I wanted to collect the data, but I could not collect the data from our Karimnagar point of view. Why the incidence of pancreatitis is very common in Karimnagar? Probably that is something to do with alcoholism. Maybe something to do with alcoholism. What is the age? Most of the times, young men and old women. This is the peak age is younger women is a very common, and old women is very common. Why there is a old women pancreatitis is common? All of you can imagine. Most of the women are likely to have gallstone diseases. Now, what is the etiology? This is one thing anybody wants to know about the mnemonic. This is I get smashed. I means idiopathic. G means gallstones, ethanol, trauma, steroids, viral, autoimmune, scorpion string, hypercalcemia, ERCP, and drugs. Now, but let us come to the correct point of view. Let me highlight to you what are the causes of acute pancreatitis. Regarding gallstones and alcohol, anyhow, I am going to highlight it to a certain extent in detail. But I wanted to highlight today most important problems now. We are able to see lots of idiopathic pancreatitis. Why idiopathic pancreatitis? Now, after every study, after doing a good work on idiopathic pancreatitis, most of these pancreatitis are due to gallstone sludge. And thanks to EUS, endoscopic ultrasound, we are attributing most of this idiopathic pancreatitis as a stone disease. Now, another area of interest is autoimmune pancreatitis. See, you have to imagine, depending upon the age, sex, when you should suspect the etiology of the acute pancreatitis could be autoimmune in a females, 20, 30 years. That is the importance of knowing about the autoimmune. IgG4, that is the most important, but one must be conscious if an young lady is presenting with an acute pancreatitis, you have to think of an autoimmune disease. Now, if a child is presenting with an acute pancreatitis, what would the possible cause? Pancreatic division is one of the most common cause we are able to see. And unfortunately, we are not having a satisfactory answer to prevent an recurrent acute pancreatitis in a setup of a pancreatic division. Now, coming to autoimmune pancreatitis, I have already highlighted to you, and hyperlipidemia. And let me quote to you, in our Pratima, we have seen at least 4 or 5 cases of hyperlipidemia presenting with an acute pancreatitis. In initial stages, we could not come to conclusion, but when we are later focused on, when we are focusing what are the etiological factors for acute pancreatitis, we are able to pick up hyperlipidemia. And moreover, it is one of the simple way to control an recurrent acute pancreatitis in a hyperlipidemia situation. because we can start put them on statins and regularly monitor their lipid profile status. Most of them, they are having good life and leading good life. Why I'm stressing this point, when I'm going to in detail, I will explain to that about the etiological factors. Now, a brief pathogenesis, probably it may be boring to you, but I will just finish off in 5 minutes. Now, first thing is ductal obstructions. Most of the gallstones, most of the biliary cholangitis, strictures, and all of them, they lead to ductal obstruction. What can happen in ductal obstruction? It leads to ductal hypertension, ischemia, ductal hypertension, ductal congregations, impaired blood flow, and ischemia, leading into ultimately everything leads to SNR injury, liberating all pancreatic enzymes. Now, something about SNR cell injury. In what are the other etiological factors they are operating through SNR cell injury? Alcohol is another component. It will operate through the ductal obstruction. It will component of this thing. Release of intracellular proenzymes, lysozymes, they activate the enzymes and leading to SNR injury. And defective intracellular transport. This I will not focus you much. It's too tough. So ultimately, all these factors are contributing what is to be an SNR cell injury. What is happening with the SNR cell? It is liberating enzymes. Trypsinogen is converted into trypsin, which is acting on prolipase and elastase. All these things are converted into elastase, lipase, which are causing cellular damage, vessel damage, and necrosis. All of them, they lead to all these complications leading into. This is in nutshell about what is the pathogenesis involved in acute pancreatitis. Now, coming to the most important component of our presentation, clinical pictures. Pain. What is the character of this pain? Let me tell you, and you see one of the marker by which most of us can make a diagnosis. Patient presenting with an upper abdominal pain. What is the peculiarity of the acute pancreatitis upper abdominal pain? Severe, excruciating pain. And patient comes to you with perspiration. And pain is radiating to back. That is another, and moreover, whenever patients leans forward, it gets a relief. This is very typical representation. And intensity of the pain. There are only two abdominal pain which have got so much of intensity other than the pancreatitis is ischemia. Ischemic bowel diseases, ischemic components, they will have severe pain. But it's a pancreatic pain is very peculiar. It is confined to upper abdominal, commonly seen after alcoholism, commonly seen in a patient with a gallstone diseases, and they present with a severe acute abdominal pain, which is radiating to back, associated with sweating, mimicking like a MI, and also radiating to back. This is very typical presentation of a pain in the acute pancreatitis, and which is refractory to the conventional analgesia. I am going to discuss how are you going to manage the pain component. And any acute abdominal pain with a nausea, which is a non-specific symptom for anybody, repeated vomiting, retching. This is another observation I make in my practice. Retching is another component very commonly seen in pancreatitis. Now, coming to the signs. Most important, you may see the patient may be a patient with mild symptoms and moderate symptoms. He may come in a good condition. But there is other spectrum of patients where you may see at the first sitting itself, patient may be gravely ill. And depending upon the severity of the pancreas, most of the symptoms, most of the signs gets altered. Patient may have a tachycardia, patient may have a tachypnea, patient may have a hypotension, and mild icterus. That is another point. All of you, it's my advice to clinicians and juniors, please search for the icterus. Any pancreatitis pain associated with icterus, it is giving a clue that are we dealing with a gallstone disease. See, every effort should be made when you are examining what could be the cause of these problems. Now, great under sign, I am going to show that coolant sign. They're all severe signs. Sometimes patient may present with an acute ascites and pleural effusion. And when he is coming to the local examination of the abdomen, very typical. Patient has got a severe guarding, rigidity, tenderness. But the guarding and rigidity, let me tell you, it is not that severe when you compare with the duodenal perforation. Here, definitely there is guarding and rigidity. But that depends upon the severity of the pancreatitis. Sometimes you may not see any guarding and rigidity. But the most important clinical sign, local clinical sign is rebound tenderness. This is very typical with associated other features and typical pain presentation, probably with the clinical also you can come to a conclusion. Sometimes symptoms may present with a pleural effusion, which is a very typical feature of a pancreatitis, that to a left-sided effusion. That depends, or the symptoms depend upon the volume of the pleural that is. Sometimes there can be a neurological derangements. What are the neurological derangements you can see in a pancreatitis is irritability and restlessness. That's another point that you have to do. Tachypnea, insomnia. That means I'm trying to tell you what are the systemic signs that you are likely to come across in an acute pancreatitis. Now, this is what is the cause of this? Because of the hemorrhage. Sometimes what happens is the blood leaks into the abdominal wall that is presented as a Cullen sign. And this is a Gray Turner sign where there is a retroperitoneal hematoma seeps into the loins. Now, before this is in a nutshell, I have cut short the clinical features. There are some other clinical features I am going to highlight when in the due course of my lecture. Now, we are entering into the most important component, that is investigations. Let me remind you, all of you, what are your objectives when you are investigating in acute pancreatitis? One, is it the diagnosis of acute pancreatitis is correct? Please let us have three objectives. When you are working on acute pancreatitis, how severe is the attack? See, first point is, are we dealing with acute pancreatitis? That means we are going to make a diagnosis by doing a diagnostic test. Then another component of investigation that we are likely to do to evaluate the severity of the pancreatitis. Next, what is the etiology? I already emphasized to you why you should know the etiology and what is your objective of evaluating the etiology so that we can predict whether the patient is likely to develop a recurrent acute pancreatitis. This is a very important point. And once you know what could be the etiology, some etiology can be attended and prevented, or recurrent pancreatitis can be prevented. Mind you, this is another issue we are facing. This recurrent acute pancreatitis, sometimes they are leading into chronic pancreatitis. So it is utmost responsibility. Most of the clinicians, let us not be happy with the clinical diagnosis. Let us see what is the severity. Why is severity? Because this is going to influence what type of management we are likely to do. And another is, what is the purpose of etiology? I have already explained to you. Now, coming to the investigations, and all of you know, whenever you are presenting any abdominal pain, nowadays, please, or it's my request to all the clinicians, please make a protocol. Every abdominal pain, do a serum amylase, lipase. We are 100% right in this protocol. Nobody can question why you are doing a lipase and amylase, though clinical picture doesn't fit in. But please do a lipase and serum amylase. Serum amylase is three times more than above normal. It's very important. And most of the times, by the time patient comes to you, unfortunately, we are not able to pick up serum amylase. But let us rely on the serum lipase. There's got a long life and more marker. It's a sensitive marker. Serum amylase is a non-specific marker. It may be elevated in other acute abdominal conditions, but that is not the case with a lipase. Lipase is mostly a sensitive marker for that. Next, estimation of serum trypsin. But this is it's a very sensitive marker, but that marker is not available in our setup. And do a serum like CBP. Most of the patients are likely to have a leukocytosis. LFT is a mandatory for two purposes. Any effect on the systemic effect on the liver because of acute pancreatitis, or patient has got an associated gallstone disease, whether it is affecting the LFT. Blood glucose, most of them, they go into hyperglycemia, serum calciumia, because it consumes lots of calcium because of the lipase and fatty acids are released, which combines with calcium and cause saponification. That leads to what is called hypercalcemia. Patient may present with tetany too. Now, what are the most important investigations that we have to take? One is plain X-ray chest, plain X-ray abdomen, ultrasound abdomen, CECT, ERCP, all said and done. Most important and the gold standard of investigation is CECT, which I'm going to highlight to that. But now, what are the points in X-ray abdomen? Most of the times it is a screening method. So what you are supposed to look in an acute pancreatitis? Any calcification, any caliculi. That's very, very important. No specific signs, evidence of a sentinel loop. I am going to project that X-ray and show you that. And X-ray chest is important to know whether a patient has got a pleural effusion. But what is the important in a plain X-ray abdomen erect? Most important is look for any calcification, any pancreatic calculi, and look for any gallstones also can be true. Other things that you can look for in this thing is for any non-specific like sentinel loop and colon cutoff site. See, this is a sentinel loop. In a jejunal loop, you can see. But the most important sign I have been observing in my clinical practice is the clinical cutoff sign, the colon cutoff sign. This is very important. You can see the transverse colon cutoff sign is the most important sign. And this is the ground glass appearance. If there is any ground glass appearance in the upper abdomen in an acute when you do an X-ray in an acute setting, most of the times it is a diagnostic. We have to go and do any further investigation to rule out pancreatitis. So in nutshell, maximum do. What to get in an acute ultrasound abdomen. Most of the times, the window may not be proper, or if the patient is obese, we may not be able to get a lot of findings. So you look for the gallstones, cholecystitis, biliary stones, pancreatic calculi, pancreatic calcification, and edematous pancreatitis. These are the most important things that we can look in an ultrasound abdomen. In a thin abdomen, most of the times an ultrasound can diagnose, coupled with enzymes and ultrasound findings, it will be suffice to know that this is a pancreatitis. This is a pancreatitis. So I am showing you this picture. So you can see an edematous pancreatitis very clearly seen. And you can nowadays, what we are doing is we can develop a window by giving a lot of water and developing a window most of the times. When facilities like CECT, people practicing in Mabzilas, talukas and mandal headquarters, you can make a reasonable diagnosis by an ultrasound, and coupled with enzymes, you can start treatment for acute pancreatitis. Now coming to the most important aspect of our diagnostic tool. CECT is the most important, and I can say it's a gold standard. But there is a lot of controversy. When to do a CECT? I'm going to give you a clear concept. When to do a CECT? Suppose a CECT is mandated very early in a particular situation where you are not able to make a diagnosis of an acute pancreatitis with other available data. Your clinical picture looks like an acute pancreatitis, but your enzymes are not fitting into that. Your ultrasound is not fitting into that. And you have to make a diagnosis. CECT is the most important imaging study that gives you even in early diagnosis. But unfortunately, we are likely to miss it. We are not able to assess the severity of the pancreatitis when you do a CECT early. So what is the ideal time? We advise most of the times in our setting, because of Arogyasri, we are forced to do after 72 hours. But ideally, we are supposed to do after 4 days. This is the ideal setting. What is the contribution of the CETC? When I already given you, there is a diagnostic uncertainty in a severe pancreatitis, and this help you to distinguish whether we are dealing with an edematous pancreatitis or whether we are dealing with a necrotism. It has got a bearing. In edematous pancreatitis, we need not admit this patient in an ICU setup. In most of the necrotizing pancreatitis, our patients are likely to have all associated systemic problems, systemic complications. They need an ICU admission. That will decide. What are the other information we are likely to get with CECT? What could be the cause? Whether it is a necrotizing, whether it is an edematous pancreatitis, whether the patient is started developing complications of pancreatitis, what are the local complications patient is developing, all these things, it is a window. That's why we rely on CECT, and most of the radiologists are also very interesting to do a CECT. The further we have what a Balthazar scoring, but I am not going to boring to you that. Now this has become a standard now, which includes CT scoring and in necrosis scoring combined. They will give you, I'll just read out, when we say CT grading with less necrotic scoring combined, 0 to 3 mild, 4 to 6 moderate. This is helping you when you are evaluating assessing the severity index of the pancreatitis, which is going to dictate what type of management I have to initiate. So that is the help that we are likely to get when it is scoring is done properly. Oh shit. Oh. with the slide. Slide move అవుతలేదు. Slide move అవుతలేదు. యా ఇప్పుడు చూడండి, మూవ్ చేయండి. ఇక్కడ చేయమంటారా? మళ్ళీ రీఎంటర్ అయిదాం, లాగిన్ అయిదాం. హలో చెప్పండి. అవట్లే అండి. సరే, ఒక్క నిమిషం.
Due to some software technical problem, sir will start another.
Just 5 minutes, 5 minutes, sir.
Maybe 5 minutes, yeah.
We'll go for home.
Come back within 1 minute. Yeah, thank you.
Yeah. Stop share on it. No. Stop share. చేసిన నా లైసెన్స్. Yeah. Hello. Am I audible?
Yes, sir.
Yeah. Let me continue, please.
Please, sir.
Sorry for the problem. Yeah, this is the CT picture, what is the normal abdomen. This is the pancreas. You can see. And you can compare with an acute pancreatitis. You can see edematous pancreatitis with fat stranding. Most important is fat stranding. You can see the collections. You can see the edematous pancreatitis. Very typical. Now, other investigations which are not done in the ERCP, not a routine investigation in an acute setting. Other investigation that we are doing in higher centers is endoscopic ultrasound. With this, we are able to diagnose acute pancreatitis, pick up the local complications, and make a diagnosis of a biliary canal, biliary sludge and disease. Now, this is not a routine investigation in an acute setting. Now, what are the differential diagnoses? We are likely to have a DD whenever we are living in acute abdominal pain. That can be confused with a duodenal perforation, cholecystitis, mesenteric ischemia, ruptured aortic aneurysm, ectopic pregnancy, salpingitis, and intestinal obstruction, diabetic ketoacidosis. Are you able to see my video? Sorry, screen. Sorry, screen.
Yes, sir.
Yeah. You are able to see my screen, no?
Yes, sir. Yes, sir.
Okay, thank you.
Yes, sir. Everybody is able to see.
Next, most important component in an acute pancreatitis, how to evaluate the severity, assessment of the severity. So far, our investigations, our approach was whether we are dealing with an acute pancreatitis. Next approach is how to evaluate the severity of the acute pancreatitis. Most of the times, we evaluate the severity of the 24 hours first, then 48 hours. By that, we can grade the pancreas. How are you going to grade? I am going to give that. Now, there are multiple scoring systems are available, but conventionally speaking, most of us, we are practicing Ranson scoring system. Now, there are two settings of Ranson scoring system, with gallstones, without gallstone, but I have given a general, this thing is, on admission, the patient is more than 55 years, where the count is more than 66,000, and the blood glucose is more than that, and we'll give every 1 point to that. Any score more than 3, that means the patient has got a severe attack. By that, you can come to a conclusion, we are dealing with a severe pancreatitis. And after 48 hours, we reevaluate, and what are the reevaluation markers? Hematocrit, blood urea raised, PO2, serum calcium, and all these things will give a fairly good idea what type of pancreatitis we are dealing with. Glasgow scoring system. Now, criteria now, another most important I wanted to give to all the practitioners. What are the systemic failure systems that are likely to be involved, and what are their presenting symptoms? For example, you take on the cardiac side, most of them, they may have an hypotension with a tachycardia, arrhythmias. And next component that is likely to be involved in a multi-system damage is a pulmonary, where a PaCO2 60 millimeters, patient has got a ARDS. And the renal output will come down, blood urea will raise, serum creatinine. This is how they're likely to manifest. In a metabolic, falling serum calcium, magnesium, albumin, and hematological falling hematocrit value. Gastrointestinal, severe ileus, and sequestration. These are what are the systems in which way they are likely to present in an acute pancreatitis. This is a clue. When you are looking when I wanted to know what is the involvement of the CVS, pulmonary, GI tract, like that. Now, taking all these things, it may confuse you. But let me give you one of the best classification from the Atlanta. This is 2012. It's a very simple classification, and it's a very good guide for routine practitioners and practitioners who are practicing in peripheral levels. What is mild? We'll divide the pancreatitis into 3 components: mild, moderate, severe. Why this is important? It will decide the treatment policy, admission policy, complication policy, outlook policy. Now, what is mild? There is no organ failure. Only patient has got local pain, symptom, and patient is not having any systemic complications. What is moderate? Organ failure, that is resolving within 48 hours. Patient might have presented with some organ failure, but that is getting resolved. Local systemic complication without persistent organ failure. Patient is likely to have some local complication and systemic complications with an organ failure in a moderate. In a severe, it's very clear. Now you are getting very clear idea. When the patient has got a persistent organ failure, single organ failure, or multiple organ failure, you can label that patient as a severe. Why this is another component, why this is important? When you are going to give the prognostics outcome, the patient tell you, what is my prognostic? Please take all these criteria when you tell what are the prognostic problems. If in a severe pancreatitis, they are likely to carry high mortality rate. But I'm telling you, an infected necrosis patient is likely to have a 40% mortality rate. This will help you how you are going to give a prognostic criteria, management criteria, admission criteria, and outlook criteria. Now, what is the management? Let me give the headings first. Then I'm going to give briefly in detail. What is the important now? What change that has taken place of late with this technology and with our better understanding of acute pancreatitis? If the patient is a mild, doesn't need an acute ICU admission. But if the patient is moderate to severe, please admit in ICU patient. Please involve critical care physician. Now, involvement of a critical care physician is a mandatory in the management of acute pancreatitis. Next, analgesia, aggressive fluid hydration, which I am going to tell you what is the most important. Supplement the oxygen, monitor vital signs, CVP, urine output, monitoring the hematological, biochemical parameters, nasogastric drainage, antibiotics if the cause of the pancreatitis is due to cholangitis. In a first stage of acute pancreatitis, there is no much role for antibiotics. But invariably, it is our routine practice, we initiate an antibiotic, supportive therapy, and nutritional support. Now, I am going to give a little bit detail about this management. Another most important point, which we are now of late, we are focusing on that, rehydration. Evaluation of hemodynamic status and rehydration. What is the fluid? How much first 48 hours, the treatment of acute pancreatitis is rehydration. There is hypovolemia. What is the fluid level that you are supposed to give? 200 to 400 ml of the fluid to be transfused per hour. 200 to 400. What fluids you like to transfuse? Simple fluids like ringer and normal saline. And that are going to give a good dehydration of the patient and prevent all the subcomplications. Because the first 2 days is dominated by hypovolemia and shock. Please rehydrate. There is an extra third loss, this thing is loss is there. That's why in acute pancreatitis, the dominant component of treatment in the initial 2 days is the treatment of dehydration, treatment of third space loss, correction of hypovolemia. Now, next component that is going to be dominated by pain. What is the ideal painkiller for this? We can try diclofenac, Promazac. Sometimes we can try phenethylamine also. Morphine should never be given for relief of the pain because that has got an action in the sphincter of Brodie. The most important pain relief. Most important is the pain relief. You can relieve the pain, most of the patients are satisfied. Otherwise, they will go into tachycardia, unrelated problems. And this nasogastric aspiration is optional. Most of the times nowadays, we are not doing nasogastric aspiration. But the idea of putting the nasogastric aspiration is so that we can relieve the GI secretion that may give a relief to the pain. Now, antibiotics, it depends upon the situation, depends upon what could have been the cause of acute pancreatitis. But nevertheless, most of the times we start antibiotics. And calcium gluconate, CVP line is essential almost in every patient whenever a patient is in ICU. But the CVP line will give you how you are going to calculate your rehydration fluids. And proper electrolyte management, it is needless to say, it is a modern marker we are almost doing every time. ABG, electrolytes, nastrogenal placement for feeding. Early feeding is another component that has really changed the management of acute pancreatitis. Hitherto, we used to insist them on NBM status and all those things. But now we are learning, we are starting early feeds. If feeding is necessary, we can put a nasogenal feed and start because that is going to contribute for early recovery. Now, management of complications like acute liver injury, atelectasis. Now, I am going to give a small mnemonic. It can be given. What pancreas? First, P means pain relief. I already told you, mepethidine, morphine, diclofenac, whatever this thing. And protease inhibitors, they were once used to be, they are popular, aparotonin and anti-snake venom. None of them are working. Please don't bother about that. Pain relief is the most important. Antibiotics, most of them you can have third generation cephalosporins, ceftazidime, cefporazone, cefitoxamine. And anticholinergics also help. Nasogastric aspiration, nutritional support. C means calcium gluconate. R means rehydration. E means endotracheal intubation if necessary, correction of electrolytes. A means antacids. And SWAN and for CVP management. This is the pancreas. From pancreas, you can develop by this mnemonic, you can develop what is your guideline for the management of an acute pancreatitis. pancreatitis. Now, what are the indications for a surgical management in acute pancreatitis? There is no indication for acute management of surgical management in acute pancreatitis is very rare. Now, sometimes what happened in earlier days when we are not having so many diagnostic markers, in an acute abdomen, we used to do an early laparotomies to diagnose only acute pancreatitis. But for the disease itself, the management of surgical management is limited role, but it has got a role in the late complications. I have already highlighted to you, now we are passing on from early phase to, now we are entering into the late phase of complication, where local complications dominate. They may need a surgical interventions. Now, what are the methods that we have to need in a management of surgical management of acute pancreatitis? When late complications are starting to develop, what are the late complications that are likely to develop? Acute pancreatitis, necrosis, walled-off necrosis, pancreatic abscess, all these things, they may require surgical management. Now, one more thing is, now how are you going to do a necrosectomy? It is beyond our this thing. Nowadays we are doing necrosectomy by open laparotomy method, by laparoscopy method. That too, when we have to do almost after 6 to 8 weeks of this thing. Necrosectomy should be planned not in an acute setting. All the late complications should be managed in the later manner. Beggars lavage, that means by continuous drainage, and laparoscopy guided. These are the methods by which we are likely to attend to the local complications of pancreatitis in the later date. Now, complications, a little bit about the complications. I already highlighted to the systemic complications like CVC, shock, and all those things. Let me focus on the local complications. I'm going to speak very briefly about the local complications. Now, what are the local complications that are dominating and that are really we are facing in acute pancreatitis? One is acute fluid collection. What do you mean by an acute fluid collection? In an acute pancreatitis setting, what happens is lots of fluid is liberated, and that may get collected in and around the pancreas. Generally, that it responds to conservative management. Very rarely, we may have to aspirate to relieve some pressure symptoms. That is one point. Acute fluid collection. Acute fluid collection is an early stage. It's commonly seen in acute pancreatitis, more commonly seen in necrotizing pancreatitis. Sterile pancreatic necrosis. Now, how are you going to diagnose a necrosis? The CECT is the modality. What is the finding? Non-visualization of any pancreas is a sign of necrotizing pancreatitis. What is the fate of a necrotizing pancreatitis? Sometimes, now the necrotizing pancreatitis is divided into two components, whether it's infected necrosis or a non-infected necrosis. Let me tell you briefly about the non-infected necrosis, which can manage conservatively most of the time that it doesn't require any surgical intervention. But a situation may come when the necrosis gets walled off, you may have to interfere with a surgical component. In an infected necrosis situation, we may have to do a necrosectomy and drain the abscesses. Now, other components is pancreatic abscess, pseudocyst, pancreatic ascites, and pleural effusion. Now, let me show you. This is acute pancreatic fluid collection. This is acute pancreatic fluid collection. This is one of the common local complications that we observe. Occurs early in the course of mild pancreatitis, non-capsule, it doesn't have a capsule as opposed to a pseudocyst, and is confined to normal facial planes. No intervention, usually not necessary. When you are likely to intervene, when it is causing discomfort, patient has got a diaphragmatic movement restriction, or it is pressing over the vital organs, you can do what is called percutaneous guided drainage that will relieve most of this. And it is self-limiting disease. Most of the time they respond nicely with conservative and limited aspiration. Now coming to I already highlighted to you what is sterile and what is infected necrosis. This is a necrosis. How are you going to diagnose? I told you. What is the fate of infected necrosis? It may become an infected necrosis or it may become a pancreatic abscess. We have got various modalities, how we are managing this. Now, acute necrotic collection with infection and heterogeneous collection these are the two ways that we can manage that. Okay. Now, this is so-called, we are learning now. What is dominating now? Earlier, we never know so many details about the necrosis of the pancreas. Now, what is happening is this necrosis, sometimes it is resolving, sometimes it is forming what is called walled-off necrosis. How do you diagnose? It is almost resembles like a pseudocyst, but you can see a lot of sludge. lot of solid material. In case of a cystic collection, it is nothing but a walled off necrosis. Walled off necrosis is managed at a later date, depending upon the location, depending upon the situation. Either way, we may manage with a cystogastrostomy, or we can manage with other methods of walled off necrosis. Now coming to Malivenda. Ledu. Oh. Yeah. Very popular common complication. Most of you know about the pseudocyst. This is collection of a fluid commonly seen in edematous pancreatitis, very rarely seen in necrotizing pancreatitis. Necrotizing pancreatitis is dominated with other local complications, and most of this edematous pancreatitis, which are the pancreatitis which are likely to develop these pseudocystis, commonly seen in trauma, commonly seen in alcoholic pancreatitis, and in a chronic pancreatitis can develop and this pseudocyst can be extrapancreatic and intrapancreatic, and it can collect in the entire lesser sac. It can collect in the greater omentum. It can collect any part of the lesser sac. Now, what are the manifestations? Most of these acute pseudocysts can be managed conservatively. Now, there is what is called rule of 6 is there, 6 weeks, 6 millimeters thickness of the wall. They may need, and they are causing symptoms to the patient, they may need intervention, surgical intervention of the pseudocyst. Now, there's a lot of development has taken place. Now, they are managed by various methods. Now, the pseudocyst, which used to be the only surgery was the modality of the management in the earlier days. Now, people are able to manage endoscopically, laparoscopically by open method. The most popular pseudocyst surgery that we do is cystogastrostomy. Other places we can do cystogenostomy, cystoduodenostomy. There are various options. That option is divided depending upon the cyst location. And nowadays, most of these in higher centers, in a corporate setup, in a surgical gastroenterology setup, most of them, they are managed with laparoscopy. There is a competition to do an endoscopically or a laparoscopically, but people say ideal method of management of a pseudocyst is still the surgery. Surgery is the best modality to manage the pseudocyst. When to manage that, we have to take a decision depending on the size of the cyst, duration of the cyst, and whether it's a symptomatic cyst or asymptomatic. All these things will give you information. And what are the investigations we are supposed to do in a pseudocyst situation? Ultrasound, CECT, MRCP. These are the investigations we are likely to do. Ultrasound, CECT, UES, MRCP. And we have to establish communication with these ductal anomalies. Pseudocyst will not resolve when we should contemplate to do surgery. If the pseudocyst is not resolving after 6 weeks, more than 6 meter size, and develop after a chronic pancreatitis, those pseudocysts, they need to be managed surgically. What are the complications of the pseudocyst? If they don't manage properly, it is likely to get infected. There can be rupture, there can be bleeding, there can be enlarged and pressure effects. Now, this is a classical diagram. I already told you this can be approached by laparoscopy. This can be approached by an open surgery. This procedure is called cystogastrostomy. You are able to see the stomach. We have done an anterior gastrotomy. We have done the posterior gastrotomy. We have opened the sac and we have let out the fluid and drained this. And most of the patients, they carry good prognosis. Yeah. So with this, I am going to conclude my lecture. And I would like to thank our IMA people. And any questions, I am welcome to answer, please. Thank you, one and all. Hello? Hello?
Oh, hello, sir.
So that is I conclude.
It's a very good oration, sir. Hello, sir. Ravindra Rao, sir.
Yeah, I am able to listen.
Hello.
Sir. Hello, sir.
Sir, you have just covered each and everything, starting from anatomy, physiology, and its etiology, disease, and its various, how to diagnose, how to treat. So I don't think there is any doubt to
Any questions are there? I am ready to answer.
Questions cannot be asked, sir, because everybody's it will be muted.
Okay. That's all. That is all.
We cannot expect any questions from the audience, sir.
Sir,
Only they can listen.
Acute, sir, will acute pancreatitis cause diabetes mellitus, sir?
Yeah, it can lead to very rare situation. Suppose if it is an acute necrotizing pancreatitis, if there is a 70% of the damage of pancreas, it may lead to diabetes, but not routinely. That depends upon the necrosis component of necrosis in the pancreas. Generally, edematous pancreatitis is not going to cause that.
Thank you, sir.
Any other question?
Sir, thank you very much, sir. Srinivas, you can ask.
Srinivas can ask me a question.
Sir, good evening, sir. Excellent program, sir. Today our viewers are 260, sir.
Thank you, sir. Thank you.
Because of your golden words and your experience about the pancreatitis, it is a ultimate coverage of from the bottom to top of the surgical point of view. Everything is covered, sir. Sir, very small doubt to make out clear to the junior colleagues or PGs. Sir, what is the role of serum lipase and amylase oral supplementation? Is it is it really helpful?
No. That is not in a acute setting. Sometimes we are trying this lipase like drugs, that is Creon and all those things in a chronic pancreatitis setting. Only thing is, Srinivas, what is very important is it is better to know what is the etiology of the acute pancreatitis. That's very, very important. And another point I wanted to give a message to this thing is alcohol. What is the involvement of alcohol? In what way it is causing a lot of damage? It causes hypersecretion, gallstone concretions, and it causes a lot of acute edematous pancreatitis and giving a lot of complications. And one of the main cause in Telangana is an alcohol. If you can prevail upon population that if we can stop alcoholism, probably the incidence of acute pancreatitis will come down. That is my message to all my colleagues and juniors to convey to the society.
Thank you, sir.
Sir, it is very difficult, sir. Very difficult to control the alcoholism in Telangana, at least because people are so much addicted for it. Every now and then, the youngsters, more of young people are
modern focus of disease management is how to prevent the disease. That's very important.
That is absolutely. Okay, thank you very much, sir, for your elaborate and very good lecture. Even the juniors or even MBBS students can easily understand, and a senior surgeons like me or this Dr. Srinivas, we are also very much happy to hear you, sir. Thank you, sir.
Thank you, sir. It's a wonderful oration.
I think I don't need you. Necessarily you are retaining. You can. Thank you very nice.
For the practitioners.
So
we have a very number of viewers here across 3 states, sir. Telangana, apart from Telangana state, Andhra Pradesh, and also there are viewers are there. Among them are noted Dwarkanath Reddy sir, Dr. Dwarkanath Reddy sir from Hyderabad, Anand Bokre, Dr. Gopal Rao, Dr. Sriram Reddy sir, and Dr. Shiva Subramaniam sir from Warangal. And from Karimnagar, we have Rayeshwar sir, ENT, Dr. Ravindra Reddy Cardiology, and Adapu Jairam sir, Ratnakar Ravikant, and Pradeep, and MLN Reddy, Dr. B.N. Rao, Dr. Venkat Reddy, Dr. Mallesham Peddapalli, and the list goes on, sir. So thank you, sir. Thank you very much. And now, presentation. Now I request Dr. Vasantrao sir, Vasantrao, to present a to present a memento to Dr. Kishan. Kishan sir. Welcome.
I request our awards committee member as well as the backbone of this. I request Dr. Kishan sir, awards committee member as well as backbone of this orations, to accept a small memento and felicitate our. No, no. Shalu with Dr. Srinivas, treasurer. Then a memento with Srinu Chebet to our beloved senior and South India President of Psychiatry Association. Thank you very much, sir, for your guiding and cooperation. Thank you very much. Long live IMA.
I request Dr. Kishan sir to present to Dr. Vasantrao. I request Dr. Kishan sir and Dr. Vasant to present.
I request dynamic secretary, dynamite, dynamic and dynamite secretary, Ram Kiran Bhaiya, please accept the felicitation.
This credit goes to all work of Ram Kiran. The credit goes to successful program. Credit goes to Dr. Ram Kiran. That's why Ninduga Shalva Kapesi. Huh? Right. Yeah.
Now Dr. Srinivas. Next vote of thanks by Dr. A. Srinivas.
Good evening to esteemed IMA members. This evening, we had a successful, very good topic, very commonly come across the problem, acute pancreatitis, which was very goodly explained by Dr. Ravindra Rao sir. So, IMA Karimnagar branch academic exercise, that is second orientation oration by name of Dr. I. Sridhar Rao Oration, orator by senior surgeon, mentor, guide to many juniors and my senior colleague, Dr. C.H. Ravindra Rao sir. Thank you very much, sir. Thanks to award committee members and special thanks to Dr. P. Kishan sir for taking an important role and made a successful second IMA oration. And I thanks to Dr. M. Vijayamohan Reddy sir, and Pulladi Srinivas Rao sir. And I also thanks to awardees, Dr. K.K. Lakshman sir, Dr. Lakshman Murthy sir, and Dr. Vijay Kumar sir. And I also thanks to senior surgeon and my senior colleague, Dr. Narendra sir, and another chairperson, Dr. Vasant Rao sir. And I also give a very good thanks to Sri Krishna of IMA, present President Dr. M. Vasant Rao. Thank you, sir. And the Krishna associated with Arjuna by Dr. Pulasa Ramkiran, sir. Thank you. Thank you very much. The both Krishna Arjuna, they made 19 and 20 years are very successful. And during the pandemic, we have done so many helpful programs to poor and needy persons. So thank you one and all. Thanks to all the viewers, and thanks to technical support which has given by the Satish and all. Thanks to Surya. Thank you, Surya. Thank you one and all. I also thanks to senior colleague Dr. Bhum Reddy sir for everything, suggestions and guidelines to this program. Thank you one and all. Long live IMA. Thank you one and all.
Now the program is closed. Oration of the program is closed. Thank you all. Long live IMA.